On this special edition of This is America and the World, 4 physicians, all experts in the field of addiction medicine, continue our discussion about America's #1 health problem, alcoholism and drug addiction. This is America and the World. A big question that I have is this medically assisted treatment, where you're still treating a person with some kind of drug, but they are in treatment and the goal is recovery.
Dennis, thank you. It's really an amazing time right now. There's good evidence, and has been good evidence for the last 40 years, that medicines in support of recovery are very useful. This data goes back to looking at oral naltrexone, and in some circles very unpopular, but methadone. It's an absolutely necessary and life-saving tool.
And you know, the interesting thing is that this whole issue that we're having about medication-assisted therapy is really not new. Our founder, and when I say our, I'm talking about the American Society of Addiction Medicine, Ruth Fox, used to prescribe Antabuse to all of her patients who had alcohol dependence. So this discussion that we're having now is really an old issue, and in fact, medication-assisted therapy for some people is the prescription that they need in order to get into.
And then when you and I talked, we were talking about methadone in the 70s or so, but there's new drugs in play now in this area of medically assisted treatment or therapy, Dr. Olsen?
Right. So, I mean, I think we really are at a wonderful place in addiction medicine, and particularly with the treatment of opioid addiction, that, you know, for a long time we only had methadone, which was very effective for many people, but was very limited in where you could actually access it. Now, in the past 20, 25 years, we've had the addition of buprenorphine, or Suboxone, as many people might know it, and also now injectable naltrexone, or Vivitrol, and all 3 of them are different. They work differently. They have different, side effect profiles. And not one is going to work for everybody, but it really is, I think, an exciting time to really be in this field, because we do have now options where we really didn't before.
Let me tell us, Dr. Stoller.
Well, the interesting thing also is that we have these medications, they exist. They've been studied for years. Methadone is the most studied medication for any chronic disease. However, when Dr. Olsen and I work together, it's often not educating people about the science of the medication, it's advocating. And so it's interesting to be in a scientific field, but we're finding that we're advocating because these medications aren't always accessible to the patients for many reasons, including stigma and also including payment, because not all of these options are able to be paid for by various various payers, such as methadone for many private insurance companies.
Hey, this thought just came into my mind when we talk about payment and so on and so forth. If you had a person who got into treatment, I don't even know how to phrase this question. If you got a person who has an addiction and get them into treatment, how much would that cost? And then if they didn't get into treatment, but they lived out a life of health problems that come along with addictions, what would that cost, like insurance or insurance companies?
I can tell you that for many years we have known, and we have documentation, that for every $1 that you spend in addiction treatment, you save $7 in terms of the expenditure of the entire healthcare dollar.
So that 1 to 7, can you put that into a dollar figure? Is there any way to put that into a dollar figure?
$500 billion annually relative to our health system in terms of cost of direct patient care, indirect cost of patient care, and also criminal justice and societal related expense.
Let's hold on that note. I want to say to the folks at home that we are blessed to have with us 4 physicians. We're talking about addiction. And addictions, I would gather, and I put this to the director of the White House office that specializes in this whole area of alcoholism, drug addiction, so on and so forth. #1 addictions, #1 health problem in America. #1 health problem in America. Yet we still struggle with stigma, we struggle with a disease. Anyway, 4 physicians talking about all of this. Sit tight, back on the other side. This is America and the World. This is America and the World is brought to you by the National Education Association, the U.S.-China Education Trust, and F.Y. Chang Foundation, guided by Ambassador Julia Chang Block, President. The League of Arab States, representing 350 million people in 22 member countries. Japan, history, hospitality, and advanced technology. Sharing tomorrow. Tourism, Malaysia. The Petrolin Group, expertise with integrity in the fields of oil and gas, exploration and production, energy, and infrastructure. The Rotendaro Family Trust. The Embassy Series, uniting people through musical diplomacy, presenting international artists in diplomatic settings. And Ventana Productions, television facilities, editing, and distribution services. All of a sudden, we're reading articles in newspapers, we're seeing it on television, on the internet, radio. In a left-handed way, has this opioid epidemic helped us face addictions as the #1 health problem in America?
I think so, and
But that's a horrible thing to say.
it's a horrible thing to say, but the benefits that we're going to reap are a long time coming, and this has opened up our eyes and the eyes of insurers, of physicians, and others that addiction is a serious medical problem.
There's been a humanization, I think, of this when people know someone or know a family that's been directly impacted by this disease, and it's really bringing about a cultural shift both within the recovery community through embracing tools like buprenorphine, naltrexone, and also within the healthcare system as a whole, seeing it as not just a necessity, but something that really, I think, speaks to the heart of why we all became physicians.
You know, CVS has now just put in many, many states over the counter a drug to counteract an overdose. They did the big thing with clearing out cigarettes, and there's a kind of a train moving. Dr. Olsen?
Yes, no, I would absolutely agree, and I think really this is a long time coming, and we still have a lot of work to do, but we certainly are moving in the right direction and really kind of seeing that that this is now looked at as a health problem, both among patients and family members and politicians and hopefully then also kind of ultimately the healthcare system. And I think, for me, part of really the wave of the future is going to be training young physicians and even older physicians to really embrace what they can and the role that they can play in helping their patients. Because a lot of times, they feel very hamstrung and don't really know what to do, don't really know how to address these different issues. I did an unpublished survey of kind of primary care physicians and other physician specialties in Maryland, and around their willingness to prescribe buprenorphine for the treatment of opioid addiction. And one of the biggest things that came out of that was, and the most significant predictor, was having had a positive experience taking care of someone with an opiate use disorder. And so I think for all of us who are, practicing this every day, really helping educate our colleagues and kind of showing that this can be an unbelievably rewarding profession. And when you see people who have been really severely ill and struggling, and when they kind of, start to make that progress kind of towards recovery, it is so unbelievably rewarding. I mean, I can't even imagine, it doesn't happen kind of, I think, in any area of medicine.
And this is where stepping up, if you're a comprehensive opioid treatment program or other comprehensive drug abuse treatment program, there's not only the availability of educating primary care providers, but also partnering with them. So we've been doing a lot of that work at Johns Hopkins to partner between our OTP that can give methadone if needed, but also give other medications, including naltrexone or buprenorphine, and then partnering in treatment, providing some case management, counseling services, while we have primary care providers.
So am I getting the drift here that, and well-intentioned doctors, physicians are writing the prescriptions for the opioids, but when they even spot that a person has developed a use, then an abuse of these, that they don't know how to treat them? Is that something that's in the cards? Go ahead.
That's
Doctor.
correct, Dennis. I think, unfortunately, and this was mentioned earlier
They
by
know how
both-
to prescribe, but they don't know how to treat.
Yes,
Right.
exactly.
Okay, go ahead.
And Dr. Baxter and Dr. Stoller both address this, and it really what we're looking at is the most important opportunity to intervene in the life of that patient at that time is oftentimes lost. A lot of physicians become fearful, they dehumanize the patient, and they kick them out of the office. When in reality, when we're talking about an integrative, longitudinal process of caring for patients, they would have the support of knowing exactly who to send to.
Why are physicians, and you are collectively answering, why are physicians afraid to, or are they, I should put it that way, are they afraid to confront their patients on their alcohol use, their drug use, and so on and so forth?
Yeah, I mean,
Everybody jump in.
Right.
on
I mean,
this.
I think part of it is that they're not necessarily trained well on how to effectively do that. I mean, there are now kind of screening and brief intervention referral to treatment initiatives through the federal government that can help, and there are screening tools. I think physicians really have struggled on what do they do with the answers, and
Yes.
they're conflict
Yeah.
avoidant.
And there's still this fundamental difficulty that we're having, that physicians oftentimes feel that if they talk about drugs or alcohol to their patient, that they're condemning them in some form or fashion.
The doctors
The
feel
doctors
that?
feel
The
that,
doctors
and that's
feel
why that they will not ask those questions, because they don't want to offend the
They don't
patient.
want to offend the patient.
What we're hoping to have happen is that we can get everyone to understand that addiction is a disease just like any other.
I'm so
Yep.
glad you put it on the table.
And once that you have that thought, then it's no problem when you're asking, do you exercise? Do you smoke? Do you use marijuana? Do you drink? It all falls in to the general flow of questions.
But doctor, let me ask you this question, because we kind of, when somebody would ask that of me when I was drinking, and they would say, well, do you drink? And I said, yeah. Well, there's a couple of beers, But they're always going to say a couple of beers.
Absolutely.
The good alcoholic is always going to lie
That's right.
and beat you every single time.
That's true.
So how do you get by that?
Yeah, but see, once that you put the question on the table, and as you continue to follow through with this individual, you'll be able to add more pieces to the puzzle.
More questions, huh?
Right, and primary care, I think, is
You were
actually
laughing when
Well,
Dr.
because-
Baxter and I were
yeah,
talking
well,
about
because,
this.
I think
Because I'll lie. I mean, I would lie.
But here's the thing. So as a primary care physician, primary care physicians are in such a fabulous place to actually be able to do this because they get to know their patients as people on a long-term basis. And, so it might be that, yes, maybe they don't, kind of see it this visit, but maybe they'll see it kind of at the next visit or thereafter. And if there are then also other signs or other information that they can glean from family members. I mean, primary care physicians really are in such a fabulous place to be able to identify and then start to intervene and express concern.
Let me toss this up. Heart disease, no problem. Cancer, no problem. I'm saying calling it as it is. Diabetes, no problem. So many. Why are we still battling with naming addiction as a disease? Dr. Stoller.
That stigma is still there.
Stigma.
But the good news is that I think things are starting to get better now as people realize this cuts across all demographics, all socioeconomic status. What I see now as the physicians move from not really knowing how to engage people into treatment to partnering with our agency, the questions that I get go from, well, why should I practice this? Why should I prescribe this medication? To how can I get the person treated more quickly?
I would be remiss if I didn't take advantage of just a minute with each of you to say on a day-to-day basis, what are you up to?
So I see patients part-time. in a comprehensive outpatient substance use treatment program where we also do some care coordination, case management, health promotion. We're very recovery focused, so we really help to have people achieve and sustain their recovery, and then I do a lot of advocacy.
And Dr. Stoller, on a day-to-day basis?
I'm the director of the outpatient drug abuse treatment program at Johns Hopkins Hospital. We get people with very severe substance use disorders as well as other chronic medical and psychiatric conditions coming in through the hospital, often homeless or not living in a place that's consistent with recovery. And then we provide them with addiction treatment in addition to wraparound services such as housing, psychiatric care, and so forth. I also do a lot of advocacy as well, working with Dr. Olsen and others on a state and national level.
Dr. Baxter?
Yes, I'm the president and CEO of the Professional Assistance Program of New Jersey, and what we do is that we manage addiction issues, psychiatric and other behavioral problems for all licensed healthcare professionals in New Jersey. And I also have a private addiction practice where I actually see regular patients on a daily basis.
Dr. Mendenhall?
Dennis, I'm a full-time clinician, and I support the Hazelden Betty Ford Comprehensive Opioid Response in the 12 Steps, where I work in an outpatient longitudinal setting, and we utilize 12-step-based recovery with the supportive medications in patients with opioid use disorders, things like naltrexone and buprenorphine. And I take care of patients once they've stepped down from a residential treatment environment, and we take care of those patients over a longer period of time.
You've come to us, and thank you for flying in from Oregon. Oregon is one of the states where recreational marijuana is permitted. Is that true?
Recreational cannabis was legalized by the state back in 2014.
What do you think about that?
I'm worried about that. I'm really worried about that. There's an argument that the demographic of people using marijuana probably isn't going to shift that much. My concern is that with the commercialization and the very, very high potency strains that we're starting to see.
Yes, that's huge in our area here.
We've seen dramatic increases in terms of psychotic episodes, patients being admitted to the emergency room for acute cannabis intoxication, and unfortunately, an uptick in terms of residential admissions for the treatment of cannabis use disorders.
Wow. Is it a slippery slope? What's your
I think we're
thinking?
giving a very mixed message, particularly to our young people, who really are the ones that I worry about with cannabis and kind of expanding access to cannabis, because even if it's regulated and there's an age cutoff, that it's the same as with alcohol, and we don't really have enough information, I think, from states that where this has actually these policies have taken place and been implemented, and we're still learning a lot. And I think we need to really be very, very, very thoughtful and careful about how we go about addressing cannabis and.
I want to go back and underscore this little part of the conversation that we were having. I just wanted to take advantage of the fact that you were here and talk about that from Oregon's point of view. I would think that a lot more has to be learned over long-term use and how it affects the population, but that's another conversation that we all could have. Stigma and the disease thing, and going back to you mentioning Governor Christie knowing someone. All politicians know someone who's dealing with some kind of an addiction problem. Why is it so darn difficult to get meaningful legislation through that supports the efforts that all of you are putting forth?
Well, I think that there are many factors. One is that physicians as a whole are having problems with legislation telling them how to practice. That's one battle. And we also have a problem with getting a full acceptance of this being a disease and not willful misconduct or bad behavior. In my years of practice, I have never heard anyone said, I woke up in the morning and decided I'm going to become an addict today. No one does that. And so I think that until we can get agreement across the board that we're dealing with a disease, NIH shows us that it's a disease. We have all kinds of evidence-based data that tells us it's a disease. That until we can get everybody on board, then we're going to have these pockets of resistance.
Is it a physical disease or a mental disease or an emotional disease?
It's
or
both.
It's all of
It's
all of
it's
the
all
above.
the
And I
above.
think part of this also is historical. So if you go back to the early 1900s, American medicine actually treated addiction as a disease very quickly for lots of kind of different reasons. And over the course of about 5 to 7 years, in 1914, it ended kind of in 1914. Congress passed the Harrison Act, which actually forbade physicians to treat addiction in their offices. And then kind of with prohibition, and there's some other historical people that ended up really turning it completely on its head, and physicians who treated it, they were arrested and thrown in jail. Patients became criminals, and the whole kind of area of addiction became a criminal issue.
So now we're coming around
And
full.
we're still, and that was really the policy in the U.S. For 50 years.
But we're coming around
And
to.
we're still having to kind of try and deal with that history, and we are coming around slowly but surely.
We have just a couple of minutes left, 30 seconds for each. You're walking down the hall, the program is over, and you say, I should have said this. What should you have said that you didn't? Or maybe you've covered everything you need to say.
Dennis, thank you. I think that this is definitely a physical disease. It's a mental disease. I would be remiss if I didn't say that many would argue that it's a spiritual or a philosophic disease state. And I really think that there's an opportunity now more than ever for more people to avail themselves of recovery, that there are more ways and a diversity for people to get into recovery. And I'm very, very hopeful, because I think what this means is not just life-saving, but it really represents freedom and liberation for those that are affected by this condition.
Dr. Baxter.
Very well said. In fact, I would like to leave the table with the thought that when you take care of a person with an addictive disorder, you not only help them to get well, but you treat their whole family, you treat the whole community, you treat the whole workforce. And so the sooner that we can get more understanding and cooperation in terms of trying to treat these patients, the better I think our country will be.
Thank you, Doctor. Dr. Stoller?
I love that idea of the exponential returns. It's why we all, the four of us, have the best jobs ever. And I think what I would like to stress is that we need to be delivering the message that this is, for many, a chronic, an ongoing disorder that needs ongoing attention. It's not the sort of thing where you enter rehab and you're cured. But on the other hand, that this is very treatable, and I see people changing their lives around 180 degrees, and each person has the capability to really put forward a very strong recovery and become a productive member of society, given the availability of all these sorts of treatments, not only medication treatments, but other supportive treatments as well.
Dr. Olsen, you have the last word.
Yeah, so I think would like to add that I also think that we really need to start by looking at our language. Because given that this is a disease, many of the terminologies and many of the words that we still use are not very disease-oriented or even kind of medically oriented.
For example?
Well, so for example, we use the words clean and dirty, even to describe a test result. So test results aren't necessarily clean and dirty unless there's actually something kind of in them that make them that, right?
They are what they are.
So they are what they are. They're either positive or negative, they're expected or unexpected. And so even with those simple, small little changes, we won't really be able to change the perception, I think, of and the stigma around this as a disease until we really start to change our language.
I think that you have all educated me and educated our viewers and educated, hopefully, physicians. I'm just so grateful that you all have contributed. Thank you so much. Just
Thank
a
you for having
terrific
me. Thank you for the opportunity.
Yeah.
Thank you.
Thank you.
For immediate help or more information, call this national helpline, 1-800-662-HELP, 1-800-662-4357. For information about This Is America and the World and to watch all of our programs, visit our website, thisisamerica.net, and look for us on Facebook and Twitter. This is America and the World is brought to you by the National Education Association, the U.S.-China Education Trust, and F.Y. Chang Foundation, guided by Ambassador Julia Chang Block, President. The League of Arab States, representing 350 million people in 22 member countries. Japan, history, hospitality, and advanced technology. Sharing tomorrow. Tourism Malaysia. The Petrolin Group, expertise with integrity in the fields of oil and gas, exploration and production, energy, and infrastructure. The Rotondaro Family Trust. The Embassy Series, uniting people through musical diplomacy, presenting international artists in diplomatic settings. And Ventana Productions, television facilities, editing, and distribution services.